stomach and upper small intestine. It's not working. Let's start whining. Okay. So first we're gonna talk about.
It's because you're on the wrong screen.
Hold on. Let's do this. How's that thought? Try this like windows.
We were. From the Mr.
There we go.
But wait, it ain't moving on mine now.
Is it not flipping on the?
It ain't showing on. Listen here, sis, you just gonna have to do it like this.
Yeah, I'll just do that old fashioned one. I clicked it when I first done it, and I should click it a different way though. I'll do it like this. Can y'all see that? Y'all don't. Okay. So peptic ulcer disease, PUD, erosion of the GI mucosa from HCl acid and pepsin. Suspectable areas of your GI tract, your lower esophagus, your stomach, your duodenum. Types include acute, which is superficial erosion, and chronic, which is erosion of the muscular wall with formation of a fibrous tissue, and it's present continually for a long time. It's got a longer duration. Gastric ulcers, they're more prevalent in females older than 50 years of age. Increased obstruction, risk factors, H. pylori, NSAIDs, bile reflux, increased mortality. I'm having a stroke. Mortality. High recurrence. Maybe we should have stopped a few minutes ago before I wanted to go on. Before I had my stroke. Duodenal ulcers, they're 1 to 2 centimeters, prevalent ages 35 to 45, they come from H. pylori, high HCl secretion, higher risk for COPD, cirrhosis, pancreatitis, hyperparathyroidism, Zollinger lesion syndrome, CRF. It occurs, disappears, and reoccurs. Here is just a figure from the book that just kind of shows the erosion. Here is a picture that you'd see like on your EGD. Your risk factors, like I said, your H. pylori, transmission from oral to oral or fecal to oral, has a long survival, medication-induced injury from your NSAIDs or with your steroids or anticoagulants. Lifestyle factors, alcohol use, smoking, caffeine, psychological distress. Stress is a big one to create these ulcers.
You get people that are on the vent for a long time, they can start getting ulcers from all that stress, being on the vent, being sick all the time. So a lot of times they'll give them like proton pump inhibitors or H2 blockers to try to keep them from getting those ulcers.
You know, I don't care. Gastric discomfort, 1 to 2 hours after meal, burning, or you have that gas pain. Food may worsen it. Perforation is normally the first symptom in some patients. The duodenal, burning or cramp-like pain in your mid-epigastric or in your back. This comes up about 2 to 5 hours after a meal. Other symptoms of bloating, nausea, vomiting, and like it says, it may be silent with your like older adults and your NSAIDs. Your studies, your endoscopy, obtain your specimens for H. pylori, monitor progress towards healing. The stool or breath test is a big one here. Other tests, your barium contrast, your labs, your CBC, your liver enzymes, your serum amylase, and then your stool. You're going to do your stool the bedside. Your interpretation management, your treatment goals, decrease gastric acidity, and I'm just gonna start dogging. Enhance mucosal defense mechanisms. Your conservative care. You want them to have adequate wear rest. No smoking or alcohol. Stress management. You want to modify their diet. Pain management. No NSAIDs or aspirin for 4 to 6 weeks, unless you give them with a PPI, H2 receptor. And then you do your endoscopic evaluation follow up 3 to 6 months for healing.
That table is on 907.
Let's see, hold on. Say 907.
Table 4113. A lot of good stuff in there. I just don't know if there's anything we need to take. Okay.
Yep, you're good. Drug therapy, your PPIs, antibiotics and PPI to eliminate H. pylori, patient education. You want to make sure they know to adhere to these medications because it's vital to them. Teach them about the drugs. Report recurrence of pain or blood in vomit or stool. And then your antibiotic therapy for H. pylori, 14 days of penicillin. You see H. pylori a lot. Your PPIs and proton pump inhibitors, they're more effective than H2 receptor blocker. Your cytoprotective drug therapy, your Carafate is what it actually is. I know the brand name. Sorry, can't say that. Protects your esophagus, your stomach, your duodenum. Works best in low pH. Give 1 to 2 hours before or after an acid. It binds with like digoxin, warfarin, tetracycline. So you're going to want to monitor those drugs closely. Adjunct drugs, your antacids, your H2 receptor blockers, nutritional therapy. Avoid foods that can cause distress or irritation. Avoid caffeine and alcohol. And then surgical therapies are uncommon unless you have complications or cancer. 3 major complications: hemorrhaging, perforation, gastric outlet obstruction. Hemorrhage is the most common. If it perfs, that's the most lethal because your GI contents are just spilling out. You don't want to leave it untreated because it can set up bacterial peritonitis in 6 to 12 hours. Your immediate focus is to stop that sealage and restore the blood volume. Small ones sometimes self-heal, so you want to keep monitoring for that obstruction, but a large one you have to surgically close it. If you plan to work in the OR, you will get called in the middle of the night for these, and they're a 4 or 5 hour procedure. Complications: gastric outlet obstruction, edema, inflammation, pilospasm. Scar tissue can cause obstruction in the distal stomach, your duodenum. Your stomach feels and dilates, causing discomfort, pain. It's worse at the end of the day. You may be able to visibly see it being dilated. Belching, projectile vomiting may cause relief to this. Constipation, anorexia. So treatment includes trying to decompress with NGTs, your proton pump inhibitors, your H2 receptor blockers. Pain management is big here. Fluid and electrolyte replacement, and then surgery or balloon dilation. Nursing assessment, report health information, your health history, the medications you have been on or are taking currently, surgeries you've had, other treatments, cancer, radiation, things like that. Your functional health patterns, your health perception, health management, your nutritional metabolic, your elimination, your cognitive perceptual, and then coping stress tolerance. Your nursing assessment is going to include your objective data, just your general whole body, GI, any diagnosis finding you see, your nursing diagnoses, acute pain, lack of knowledge, nausea. Your goals are to adhere to the prescribed regimen, reduce your absent discomfort, no signs of GI complications, complete healing, and then lifestyle modifications to prevent reoccurrence. Your health promotion, you want to identify your patients at risk, teach and report about gastric distress to your healthcare provider. Your acute care setting, you want these patients to be NPO. You do IV fluids, check their vital signs, monitor for shock, gastric content analysis, or checking your pH, blood, or bowel, monitoring your labs, and managing pain and anxiety. Create a restful environment for these patients. Acute care monitoring for complications, for hemorrhage, you monitor vital signs, NG aspirate. If they have a perf bowel, notify your healthcare provider, frequent vital signs, no oral or NG intake, because you don't want to put anything in if it can't come out, it's just going to be spilling over. IV fluids, pain management, you want to do antibiotics, and then you're going to prepare for surgery if needed. Monitor for complications with your gastric outlet obstruction, NGT dissection, your gate policy. Everybody's is different with their NG tubes. Monitor your I's and O's. You're going to want to reposition your patient. IV fluids, and you want to replace these electrolytes. Gastric residual if less than 200. After clamp for 8 to 12 hours, begin your oral intake, and then slowly you're going to progress to your solids. So you're going to start with your liquids and then progress. No relief or recurrence, and with surgical intervention. Ambulatory care, patient and caregiver education. That's on table 4116. Textbook, if you want to look at it. You want to prevent recurrence and complications, modify your diet, lifestyle modifications, adhere to your medication regimen, stress management, disease management, and follow-up care. Teach them what symptoms to report to your healthcare provider. Teach them that it's important to follow up with your healthcare provider. An important thing right here with dietary teaching is teach them to avoid foods that cause the pain after you eat them. Especially with like PUD, you just want them to, if you know that if you eat pizza, it's going to upset you, teach them not to eat pizza, because that's going to cause you pain. It might be pleasurable, but it's going to cause you pain when it's finishes. Your outcomes, you want your pain control without medication. They can verbalize the understanding of the treatment plan. The patient is committed to self-care and disease management. And then your goal is to have no complications. Some geriatric considerations, increased morbidity and mortality, frequent use of NSAIDs, especially for arthritis. Your first symptom may be a GI bleed. Treatment is similar to, with emphasis on teaching and prevention. I'm going to try to get through this, guys, so we can try to jump onto the next thing tomorrow and then have like a review by next week. That's okay with you all. Stomach cancer, gastric cancer, adenocarcinoma of the stomach wall. It's increased incidence in the U.S. It's more common in men than women. It's a 2-to-1 ratio. The average age is 68. It's often already went other places and metastasized when it's diagnosed. There's a 5-year survival rate if it's confined to the stomach, and then there's a 5-year survival with if it's if it's already spread, you got a 31% chance of survival. There's no specific cause. Non-specific factors such as H. pylori and autoimmune related inflammation, and just repeated exposure to things that can irritate it. Other associated or predisposing factors: smoked foods, salted fish and meat, pickled vegetables. I'm going to die soon after eating that.
Those are the best things.
I love all those things. H. pylori infection at an early age, lymphoma of the stomach, anemia, polyps, smoking and obesity is the big ones here. Spreads by direct extension, and then the liver and any adjunct tissue. Clinical manifestations: unexplained weight loss, abdominal discomfort and pain, anemia, pale, weak, fatigue, dizzy, short of breath, blood in your stool. Late signs: lymph node enlargement, ascites. Diagnostic studies: your history and physical, your upper GI endoscopic biopsy, EUS, CT, MRI, and then PET scan, which is for your staging. Your labs, your CBC, liver enzymes, amylase, tumor markers, and then the oculate blood stool sample. Surgical therapy is the best treatment. Here you can do the Billy Roth 1 or 2, because you're having lesions in your fundus. You could have a total gastrectomy, and then the other depends on if it's already metastasized or not. Kind of depends on if you can have treatment or not. Chemotherapy and radiation, combination chemo is preferred. Radiation may be done with chemo, palliative care for obstruction to reduce the tumor mass. Targeted therapy may be to kill cancer cells and then prevent your growth and spread. Nursing management, your subjective data, you want to know about the important healthcare information, your past medical history, medications, surgeries, then same as all the other ones, your functional health patterns, your perception, your nutritional metabolic, your elimination, cognitive, perceptual, and then coping, stress, and tolerance. Nursing management, your assessment, your objective data, your general, just your overall, then your GI and kidney diagnostic findings. Your nursing diagnosis, your impaired nutritional intake, your impaired nutritional status, acute pain and anxiety. Your goals: you want to have minimal discomfort, have a good nutritional status, maintain a degree of spiritual or psychological well-being appropriate to the disease state. Health promotion: you want to identify your patients at risk, recognize symptoms and unrelieved PUD. Acute care: you want to have the emotional support, nutritional support. You want to restore your fluid volume. You may give pancreatic blood cells, pre-op, post-op teaching, chemo, radiation therapy. All those can be acute care. Ambulatory at home: you want to have home health care. You have resources, community agencies that can help evaluation. You want to have minimal to no discomfort, pain or nausea, have an optimal nutritional status, and then maintain that degree of well-being appropriate to nurse. So gastric surgery, your partial gastrectomy, your gastroduodectomy, your Billy Roth 1, and then your Billy Roth 2. Then your gastrectomy removes your stomach. I have never seen a Billy Roth 1, Billy Roth 2, or a gastrectomy. But these would be like if you had that cancer, just trying to remove them. Here's like the picture of where they've like tried to cut and put back what they can with the Billy Roths. with the total, you can see that it's there's the normal and where they removed it, and then C shows like where they just like try to reconnect. They just they get rid of the just the stomach, and then they try to like route around it. I've never seen that though. I'm not sure. It must be one of the UK surgeries. It's not a hazard ORH surgery. Yeah, what's it there?
They try to avoid it because the total gastrectomy has a lot of duct.
And then
They usually try to do like a just move what has to be moved.
then try to work around it. Post-op complications, like hemorrhage is the big one, like she said, Dumpin syndrome. So gastric chine enters the small intestine as a hypertonic bolus. It pulls fluid into your bowel lumen, causing decreased plasma volume, distension of bowel lumen, and rapid transit within 15 to 30 minutes of eating. It's not good. You can have weakness, sweating, palpitations, dizziness, cramping, defecation urge, lasts about an hour, and then reduced with rest after eating. So post Pendial, how do you say that word? Postprandial hypoglycemia. It's a variant of Dumpin syndrome. It's uncontrolled high carbohydrate bolus enters the small intestine, causing excess insulin, and results in hypoglycemia. Normally 2 hours after eating. These patients sweat, have weakness, confusion, palpitations, tachycardia, and anxiety. All these are hypoglycemia reactions. Bowel reflux, gastritis, after reconstruction or removal of pylorus. Your bowel reflux causes damage to the gastric mucosa. Chronic gastritis, a PUD. Gastric distress temporarily relieves by vomiting. Your pre-op care, laparoscopic or open techniques. With any surgery like this, like gallbladder, when you're teaching these patients, make sure they understand that you want to attempt to do these laparoscopically, but you know they're taking the chance of being open. When you sign your consent, it normally says laparoscopic versus open. You try to steer away from open techniques because that's increases your risk of infection, bleeding, all these other things. They try to keep it laparoscopic, but just make sure your patient knows that there is that risk. Teach the patient about procedure and post-op expectations, comfort measures, pain management, turn, cough, and deep breathe. You're going to have an NG tube, need IV fluids. More post-op care, your fluid and electrolyte balance, IV fluids, and you're going to go oral, and then you're going to try to change them back into a solid diet, monitor their eyes and O's, do daily weights on them. With a daily weight, you want to talk to your provider and see do they want them stood up on a scale or if you can zero the bed. Different doctors have different preferences. Dr. Stumbo wants them on actually to stand on the scale, but everybody else is okay with that bed weight, so you just need to ask. You want to prevent respiratory complications, your respiratory assessment, your vital signs, your dyspnea, chest pain, cyanosis. You want to splint your incision site. A lot of the times they have a cute little pillow in the hospital they give you to kind of hold when you cough and deep breathe. You want to do early amputation and reposition frequently. So try to get them up as soon as you can after surgery. You don't want them to lay there and set up pneumonia. But you want to maintain comfort cares, pain, and you want to limit that pain, nausea, and you want to prevent infection. You want to monitor those vital signs, assess your wound, monitor for any complications, pneumonia, DVTs, PEs, pneumothoraxes. anastomosis leak, tachycardia, dyspnea, fever, abdominal pain, anxiety, being restless. This requires immediate treatment. You don't want the patient to become septic and die. And then hemorrhage, you want to monitor those vital signs, and then watch your aspirate out of your NG tube. And with that, when you're aspirating out of your NG tube and it's coming back with blood, a bit like I said earlier, if you're vomiting blood, you want to monitor that hypovolemic shock with that like blood pressure and checking that pulse because that's a big one. More post-op care, NG tube for decompression. It reduces pressure to the suture line. It decreases anemia and inflammation. You want to observe your gas, what you've aspirated, color, amount, odor. Bloody drainage is expected for 2 to 3 hours, but report an excess greater than 75 mL per hour. Monitor for clots and obstruction. Irrigate with normal saline to avoid rupture of sutures, leakage into your cavity, your hemorrhage, and then you could have an abscess form. It should darken and change to the yellow-green in 36 to 48 hours. So if you're like on hour 72 and it's still bloody, you should have already called your doctor by that point. Nutritional therapy, understanding surgical procedure and the changes. You should have the dietitian on consulted so they can come in and reinforce the instructions. Your enteral feedings or para-enteral nutrition, wound healing, your calcium, your vitamin C, K, and then your B complex. Your anemia, loss of intrinsic factor needed for absorption of your B12, essential for your red blood cells. You're going to administer your B12, your multivitamins with folate, calcium, vitamin D, and iron. Reduce stomach size, which means reduce meal size. Your first few weeks, soft, bland, low fiber, high complex carb diet with high protein. Your small, frequent meals, no fluids with your meals. Chew thoroughly. Avoid simple sugars, lactose, and fried foods. Avoid extreme food temperatures. Avoid hypoglycemia. Limit your sugars with meals. Moderate protein and fat. Patient caregiver education, your pain management, wound care, nutrition. They may need skilled care or home care services. So a big one there is you want to get like your case management on board so they can help you know what that patient's going to need at home. Your gastritis. Inflammation of your gastric mucosa. It can be acute or chronic, diffuse or localized. Breakdown in your gastric mucosal barrier, allowing HCl acid and pepsin to diffuse back into the mucosa results in tissue edema, disruption of capillary walls with loss of plasma into your gastric lumen, and possible hemorrhage. Causes can be drug related, your NSAIDs, which are increased risk. History of PUD, age over 30, if you're a female, if you're on anticoagulant therapy, steroids, or any other debilitating chronic disorders. Your diet, alcohol use, spicy, irritating foods can cause it. H. pylori, other bacterial, viral, or fungal infections, environmental, radiation, and smoking. Disease and disorder, autoimmune gastritis, burns, Crohn's disease, hiatal hernia, stress, bowel reflux, renal failure, sepsis, and shock. Manifestations in acute include anorexia, nausea, and vomiting, epigastric tenderness, hemorrhage, self-limited. Chronic is similar to acute. They may be asymptomatic or have that anemia. Diagnostic studies is based on on the symptoms, history of alcohol or drug use, endoscopy with biopsy, H. pylori testing, your CDC lab, you're doing your stool for your ocular blood, and antibodies to perineal cells and intrinsic factors. Acute gastritis, you want to identify the cause, eliminate, prevent, or avoid it. Supportive care, rest, EPO, IV fluids, anti-anemics, monitor for dehydration, severe NG tube to monitor for bleeding, lavage, empty stomach, risk for hemorrhage, monitor vital signs. You want to check your vomit for blood with the heme test, upper GI bleed strategies, drugs, your PPIs, or your H2 receptor blockers. Chronic gastritis, evaluate and eliminate your cause. You want to treat your H. pylori with antibiotics. You may be given the B12 for your anemia. Lifestyle modifications, no smoking, and then, like I said before earlier, 6 small meals a day, do the non-irritating food, and then you want to teach them that adherence to the drug regimen is important. Let me ask y'all this. We're on slide 63, and there's 81. Do y'all want to keep going? Keep going. Keep on tracking. So upper GI bleeding, you may have blood and vomit. It could be bright red, coffee ground, digested blood. It could be black and have tarry stools from your upper GI. And then your occult is a test that detects blood in your gastric secretions, your vomit, or your stool. PUD, H. pylori insects is the most common causes of stress-related mucosal disease. These stress ulcers, you're at an increased risk for critically ill, like what we was talking about earlier, ICU patients, liver disease, organ failure, renal replacement therapy. All these put you at an increased risk for upper GI bleeding. And then esophageal varices is a big one there too. Diagnostic studies, endoscopy, angiography, your labs, your CBC, your hemoglobin, and your hematocrit is the big ones there. Your BUN, your PT, your PTT, your PTINR, your ABGs, your liver enzymes, your type and cross match. You want to make sure they have a type and cross, because if they're bleeding like that, they're more than likely going to need an infusion. And then your vomit and your stool may have the blood in it. Emergency assessment and management with a massive GI bleed. It's greater than 1,500 mLs of blood. It's loss. It's 25% loss of your intravascular volume. You want to assess for shock, tachycardia, weak pulse, hypotension, pull extremities, prolonged cap refill, and apprehension. You want to monitor your urine output hourly. You have hemodynamic monitoring, your oxygen administration. You want to assess for your perforation and your peritonitis. They may have a tense, rigid abdomen. You want to check their bowel sounds, administer your IV fluids, and then you may do your blood or blood product transfusions. Endoscopic therapy is the first line management within 24 hours to determine treatment or need for surgery. Your goal is to coagulate most of the bleed. Clips or bands, which will compress the vessel, a thermal ablation, which cauterizes it, an injection, your varices, ligation, sclerotherapy, or balloon tamponade, your surgical therapy, your sites identified, and other interventions have failed. It requires more than 2,000 mLs of blood or shock. Your drug therapy, your PPI, your IV bolus and infusion, and then antacids after you get out of that acute phase. Nurse and assessment, manage physical needs before H&P. So you want to make sure you assess the patient, treat them before you go over their history and physical. Assess their level of consciousness, do your frequent vital signs, their skin color, their calf refill, any signs and symptoms of shock, their abdomen, is it distended, are they garden, determine if they've had a previous bleed, blood transfusion, have they had a transfusion reaction, do they have any other illnesses or drugs that can contribute to this bleeding, and do they have a religious preference that prohibits blood transfusion? Yes.
Ask them to make sure they're on anticoagulation,
Yeah.
Levinox,
Warfarin, all those.
all those two. I've seen that they really,
Those will make you have a bloodbath.
it really makes it bad. And a little bit of blood looks like a lot, especially when it's coming out of the
Yes,
mouth.
it's just.
FYI.
Even when you do an IV on people on those drugs, it looks like, oh my god, I just killed somebody. Your nursing diagnoses, impaired cardiac output, fluid imbalance, ineffective tissue perfusion, anxiety. Your goals include no further GI bleeding. You want to stop that. You want to identify the cause and treat it. You want to have a normal hemodynamic state. And you want to have minimal or no pain or anxiety. Health promotion, you want to identify your high-risk patients. Patient education, you want to teach them about those GI toxic drugs, NSAIDs, steroids, avoiding those gastric irritants, smoking, alcohol, certain over-the-counter meds. You want to test for your oxalate blood, and if it's positive, report to your healthcare provider. Your varices, you want to avoid pressure, severe coughing or sneezing, you want to try to limit those. Blood dyscarcia. Teach about the disease, drugs, and then the risk for GI bleeding that goes with that. Your acute care, your emergency management, you want to assess and monitor circulation, airway, breathing, your ABCs. Your IV access, you want to have 2 large bores because you want to have your IV fluids, PPIs, and then blood running. Oxygen, ECG monitoring, vital signs, level of consciousness. Have your labs, your CBC, your clotting studies like your PT, PTINR, your type and cross, your NG tube, catheter. You want to monitor your eyes and nose. With your abdomen, you want to make sure your bowel sounds are present. You're monitoring those if they're NPO. And then when you have an elder patient, you want to watch the fluid volume overload. Acute care, your NG management, make sure you have the proper position. When you aspirate, check for blood. Lavage, 50 to 100 mLs instilled and drained out. Assess your stool and vomit for blood. Oral intake, you want to monitor for nausea and vomiting. Clear liquids, you want to try to advance that diet as tolerated. Alcohol use disorder, you want to monitor for withdrawal and delirium treatment. So that's a big one. If these patients are alcoholics, they will withdraw. Patient and caregiver education for at home. You want to avoid future bleed and teach what to do if it occurs. Only take your prescribed drugs. Make sure they know not to go to Walmart and buy Motrin unless it's prescribed by the doctor. Make sure they know to stop drinking and stop smoking. And then you want to teach about long-term care and the follow-up. Go with it. Outcomes, no upper GI bleeding. You want to have a normal fluid volume, normal hemodynamic state, and then understand potential factors and make appropriate lifestyle modifications. And we are almost done. Foodborne illness. I bet everybody in here has been food poisoned or knows somebody who's been food poisoned. So GI symptoms, nausea, vomiting, diarrhea, cramping, abdominal pain due to eating or drinking a contaminated food or liquid. 250 plus illnesses, most due to bacteria during growing, harvesting, processing, storing, shipping, or final preparation. Interventions include prevention, making sure correct food preparation, cleanliness, adequate cooking, and refrigeration. Acute acute care, correct your fluid and electrolyte imbalances, monitor your CNS for botulism, your E. coli. It's a toxin that can cause hemorrhagic colitis and kidney failure, which is life-threatening. And then with the foodborne illness, a lot of the time you don't even, when you go to these restaurants, you don't know. So I know it talks a lot about the prevention and making sure it's cooked correctly, but sometimes that one can't be prevented.
We need to know much about foodborne illness for the test.
Just enough that you already know, like, what it's about. Just to correct that fluid and electrolyte imbalance and monitor your CNS with water. And then E. coli is big.
Just enough to keep ourselves alive.
It's like the, 2124, it's got like botulism and all those different kind of. Now, you teachers love those botulism techniques.
I love botulism.
You all do. You all really do like the botulism.
Are you talking about table 4124? Is that what you said?
4124.
Yeah, on those, botulism, E. coli.
Botulism, E. coli.
Yeah.
4124 on 920.
Salmonella ain't gonna be on the test, but that one's one you really do need to know about for real life. Let me go back through here real quick. Make sure I didn't miss it. I told y'all about all the drugs. I told you about the drugs on 4110.
41 what?
4110,
Yeah.
those animals.
Definitely will pass.
Yeah.
But that, what about 41-1, that very first one's got that old nerve disease,
No.
none of that.
Mm-mm.
Okay.
Yep. Only one that's really that you may see on the test that's on there is Zofran.
Yeah.
That's
Odonostream.
yeah, that good one.
And 90% of us take it. So
Take it or give it.
I have some in my purse if anybody needs it.
I've got some in my backpack.
I got Peter getting me some of that. Okay. That's about all I know.
894.
893.
41.
No.
Nothing.
No, we didn't go over any of that, so nope. You can look over it. Stuff that probably will need real life. We didn't hit it, so we ain't doing it.
When you bring these papers to clinicals, you gotta have the result with them, because these have to go to CAP. Got the email.